Welcome everyone to our last Monday seminar of the semester. Today we have Sadiq Patel, who is an experienced data scientist and health technologist with 10 plus years of experience in health AI, health data, and health economics. At Waymark, a health tech startup, his team oversees data strategy and governance and the design, build, and deployment of ML, AI, LLM-informed data science tools to improve effectiveness, efficiency, and automation of care delivery. He is also an adjunct professor at the University of Pennsylvania, where he teaches graduate level machine learning courses. Prior to Waymark, Sadiq was a research fellow at Harvard Medical School and Microsoft AI for Good. Senior data scientist and team lead at Accenture for commercial and government clients, and educator through Teach for America. He holds a PhD and MS in social policy and biostatistics from the University of Chicago, MSW from the University of Michigan, and a BS in biochemistry and mathematics from the University of Illinois, where he studied as a Howard Hughes medical scholar. Sadiq's research has been published in healthcare and medical journals, including JAMA, British Medical Journal, Nature, Health Affairs Blog, and American Journal of Public Health. His work has been featured in major media, including the Wall Street Journal, presented to the Congressional Budget Office, and cited in congressional hearings and Supreme Court briefs. Thanks so much for being here, Sadiq. It's all yours.
Thank you so much. It's such an honor to be here. Thank you, Rebecca. And I have to note that a lot of the work that was published that Rebecca mentioned, she was definitely part of some of that research. She worked as an RA in our lab at the time and was a big contributor to a lot of that work. So I'm so excited to be here. I'm going to share my screen first and maybe give you a little bit more of the flavor of the kind of work we do at Waymark. Waymark is a health tech startup. It was started by two professors, Sanjay Basu from Stanford, and then Rajay Bhatniji, Stanford and University of California, San Francisco. Both are physician researchers. And they had this idea that in order to create effective Medicaid care delivery, you have to effectively build a strong Medicaid community health worker care delivery model, where you hire individuals who live in the communities that the patients are from, and now you have individuals that could best serve Medicaid patients within those communities, both in terms of connecting them to local primary care, but also in terms of connecting them to local CBOs, basically CBOs being local housing resources, local food support source resources, basically any community-based organization that serves the social needs of Medicaid patients in particular. And so one of the key ideas behind a community health program care delivery wasn't so much the actual care delivery model itself. That model has been replicated by both researchers through grant-funded research initiatives, but also through other commercial organizations. You have MedSed out there. You have other organizations that are doing equality health, that are building community-based care delivery models for Medicaid and doing it in a manner where it's both sustainable and scalable. And so the question becomes, what differentiated Waymark and the work we're doing from any of these other organizations that are doing similar work? And a lot of that is in terms of our AI, ML, and now more recently, LLM capabilities, that through data science, you can effectively build data science tools that address effectiveness. So how do you target the right patients? If you have a panel of 50,000 Medicaid patients you have to deliver care to, how do you find which patients you want to effectively target your resources to, those in-person individuals? And in a lot of Medicaid care delivery programs, those are called your high-risk patients. We call them rising risk patients. Those patients that we can intervene on, and if we do it early on, it will prevent acute care visits like hospital visits and ED visits that are very costly. The second idea or prong is, how do you build data science tools that address this problem of efficiency? So you have the right patients, you know who you have to target, you know it's these 10,000 patients. Well, how do you allow your CHWs to decrease the amount of time they spend with administrative work and increase the amount of time basically providing empathetic, patient-centered, patient-focused care delivery, right? And we find that by using empathy, but also by increasing the amount of time a community health worker has to actually spend with the patient, results in longer term better health outcomes. And so how do you automate the generation of patient notes? How do you increase the likelihood of a patient not canceling an appointment? Increase the likelihood of when you call the patient, they'll pick up instead of having to call them 4 or 5 times and now spending an hour just trying to get a hold of them. And then the final idea behind Waymark is this idea of automation. I think Rebecca mentioned it. You know, AI increasingly allows us to automate functions that in previous worlds a human being would have to do. And so how do you automate outreach to patients, sending a text message, asking them if they want to enroll in our program without a human being having to do that? How do you automate scheduling a PCP visit without a human being, a care worker, having to call the office and spend an hour for each patient? How do you do that through an AI voice bot? And so those are the ideas behind Waymark. What we're going to focus on today is really the idea of that first prong. How do you identify those patients that you want to deliver care to? And so this goes back to a paper that we published recently in Nature, Prediction of Non-Emergent Acute Care Utilization and Cost Among Patients Receiving Medicaid. And I'm going to work through the paper and talk through the background, you know, what's been out there with risk modeling. Medicaid is the most costly government health program in the United States. And how is it to date that we don't have an effective risk model, or the risk models that are currently used by states were developed in the late 1990s, right? We're going to talk about the research aim of the paper. What was the problem we're trying to solve, the methods, the results, limitations, and some discussion. And I'm going to save a lot of time for Q&A, hopefully. Here is the actual publication. So for those of you that want more detail, here's the citation at the bottom. Welcome you to review the paper itself and the appendix, and it will give you a lot of the finer details that you might be interested in terms of how we implemented the machine learning models, which models we chose, what were some of the sensitivity analyses that we ran to address some of the limitations of those models. Random forest is very sensitive to imbalance labels. How did we overcome that, and so forth. Here's a press release. You're more than welcome to go and review it, but it gives you a better idea of how this paper fits into the broader picture or question of how do you effectively mobilize a care delivery program in order to reach the patients where we can have the most impact on. So a little background. So Medicaid patients disproportionately experience social risk factors for poor health and limited access to primary care. This is a well-known well-studied problem. It results in high utilization of emergency departments and hospital visits for non-emergent conditions. What do I mean by non-emergent conditions? These are visits that folks like you and I that have connections to primary care offices would make a visit with our PCP and see them in the same week if it was something that was urgent. If it was something that was non-urgent, maybe we would wait a week. For Medicaid patients, because they don't have that same connections to local primary care, often rely on the hospital or the ED services as that first layer of care for themselves. And oftentimes, you know, ED visits and hospitalizations are 10x more costly, but also the quality of care is much lower. They're not building a sustainable long-term relationship with one primary care physician who understands their unique social and health needs. You know, proactive Medicaid programs, you know, City Block, MedZed, Equality Health, Waymark, attempt to contact at-risk patients, but typically they're based on risk models trained to predict high healthcare costs and offer patients additional support to access primary care. Those programs able to contact patients deemed at risk before they experience disease complications. And so we sort of refactored high risk to rising risk. Who are those individuals whose risk level is increasing over time, such that if we intervene, we could avoid utilization of like acute care, hospitalizations, and ED visits. Risk modeling for Medicaid has suffered from incomplete and poor quality data, lack of unification of data across states, and poor availability of metrics of social determinants of health. And so 3 major questions have emerged from a National Academy of Medicine report related to using machine learning to improve community-based outreach to marginalized populations, such as patients receiving Medicaid. And so first, the first thing they highlighted was following a recent multi-state effort to improve the comprehensiveness and uniformity of data across over 24 states for patients receiving Medicaid. Does retraining models across the newly available unified data set improve risk model performance? And the newer data have the critical features of linking healthcare claims across the same individuals over time with greater reliability. It enables modeling of individual healthcare trajectories, not just brief episodes of care. The second idea that they brought up was, do metrics of social determinants of health allow us to capture complex interactions between social risk factors and healthcare utilization? You know, one idea that we always posit, and that's supported by prior literature, is air pollution metrics may improve prediction of acute care for chronic lung diseases, while metrics of healthy food availability may improve prediction of acute care for diabetes. And while traditional logistic regression models have been used to model risk in Medicaid, newer machine learning models may better capture nonlinear and complex interactions between social determinants of health and healthcare utilization. And then finally, can we reduce race and ethnic bias observed in models that are focused on predicting cost? You know, because Black patients in particular have lower access to high-cost healthcare centers, such as tertiary care specialty centers, they tend to have lower cost than white patients with the same severity of diseases. And it has been proposed that alternative modeling methods focusing on combinations of social risk and utilization rather than cost prediction alone may actually reduce underestimation of risk among Black patients, but the hypothesis remains untested. And there was that Nature article a few years ago that showed, it was in the New York Times as well, that showed that systematically within certain healthcare systems, Black patients with the same severity of disease compared to white patients were actually their risk was being under predicted compared to white patients. And there was more care delivery directed towards white patients versus African-American patients. And so one of the questions that we thought was, by incorporating social risk factors like social determinants of health in conjunction with focusing on utilization of acute care for non-emergent conditions versus cost, may help us overcome some of the challenges with under predicting risk for African-American patients compared to white patients. And so our research aim was effectively, we compared different modeling approaches to predict the risks of all-cause and non-emergent acute care utilization and cost. And so our methods, you know, our study design and conceptual model is as follows. So we sort of had three main components for this paper. First, we wanted to test conventional Medicaid risk models. So the conventional Medicaid risk model that exists right now is CDPS. It's used by 18 states, I think up somewhere 18 north of 25. It was a risk model generated in the late 1990s by University of California, San Diego. It's been very effective, but it typically incorporates patient demographic data, age, sex, race, ethnicity, healthcare diagnostic and procedural codes, and medication information. And so, and they use a logistic regression model, or they focus more on regression analysis. What we wanted to do is we wanted to compare the conventional Medicaid risk model to a second risk model, where we incorporate cumulative risk and risk trajectories of patients to capture the progressive nature of chronic conditions that contribute to acute care utilization. I'll explain what those features incorporate when I describe the predictors of the model. And then finally, we tested a third layer. We said, okay, we'll have the conventional risk model. We'll add something called cumulative risk and risk trajectories, and then we'll layer that with both social determinants of health information, both individual level, but also community level. And so on the individual level, which I'll explain later, we look at the number of members in a family, their family income, the citizenship status, all information that's incorporated in our data set. But then we also look at the community at the county level. We look at the poverty level, local access to primary care, local access to hospitals. We look at pollution and other community factors that we can measure. And then what we did was we said, we have these three competing models, but we want to understand to what extent does prediction using newer machine learning methods compare to utilizing standard statistical models like regression. And so we wanted to understand not only by looking at the features, but by looking at the modeling approaches itself. Does machine learning add additional value in a way that traditional statistical models may not, especially with the utilization of big data? And so our data resource, we use the TMSIS or TAF. This is the newest national Medicaid data set. For those of you familiar with Medicaid, it replaced MAX. And so we use data from 2017 to 2019, the most recent available years not affected by COVID. So right now, TMSIS offers data through 2020 and the VRDC through CMS. So we used it through 2019 because we felt that COVID impacted some of the utilization measures in 2020. In addition to providing the national data set for all Medicaid patients, it incorporated individual level ESTO metrics, geographic information in terms of the zip code and county the member lived in. And it also incorporated claims for outpatient, inpatient, long-term support, medication, pharmacy, and other healthcare services. And then what we did is we used DQ Atlas. It's a website that was created to assess the quality of TMSIS data. So unlike Medicare data, which is aggregated at the federal level, TMSIS data is aggregated by each state, and each state has different standards of quality. And so there was a national effort to effectively create metrics and evaluate the quality of each state's Medicaid data. And that's on DQ Atlas's website. And so that we were able to assess which states actually provide us with the quality that gives us confidence to include that as part of our sample. We included the study population enrollment and follow-up timeline. We included individuals whose first month of enrollment in Medicaid occurred between 2017 and 2018. And we basically analyzed the subsequent 12 months of utilization and cost, a period that we chose that was directly comparable to prior Medicaid risk model studies. And we measured our predictors in that first 6-month period. And we measured the outcome measure in that second 6-month period. So we looked at 12 months, we measured predictors in that first 6 months and the outcome in that second 6 months. And this was in order to make it a prospective risk model. And we excluded individuals who were dually enrolled in both Medicare and Medicaid. As you know, dual enrollment means that Medicare pays for some of the health utilization, and we wouldn't see those claims in the Medicaid data. We'd have to look at Medicare instead. And we effectively developed models to predict 4 outcomes. First, we developed the disenrollment from Medicaid, which I'll explain later. We predicted having at least one all-cause ED visit or hospitalization. So all-cause means any ED visit or hospitalization. It includes non-emergent and emergent ED visits, those visits that are not avoidable. And then we had having at least one non-emergent ED visit or hospitalization, and we looked at the total cost of care. We defined non-emergent ED visits using the NYU University ED patch algorithm definition. And we define non-emergent hospitalizations, but using the Agency of Healthcare Research and Quality definitions of a preventable quality indicator. And then our predictors in the model, and then I'll pause there if there's any questions before I go forward, but we looked at demographics. So, the usual suspects, age, race, sex. We looked at the clinical history in that 6-month period. Looking at diagnosis, medication adherence, the type of medications you were taking. And then we measure cumulative risk and risk trajectories. And one example I give of this is sort of like, imagine if you had 2 patients. One patient is increasing their use of ED visits, right, over time. So in the first month, they have none. Second month, they have 1. In the third month, they have 3 visits, then 5 visits. They're increasing, right? And then imagine a second patient who has the same number of visits in that 6-month period, but it's decreasing. So they have the opposite pattern. 5 months, 5 in the first month, then 3, then 2, then 1. And you might look at those patients and say in totality, they have the same risk. But when you look at their slope, you look at one and you say, well, they're decreasing over time. So that might be an indication that their risk or their reliance on acute care is decreasing or diminishing. And you might look at the other one and say it's increasing, higher risk. And so we wanted to create unique features to capture that that nuance, to understand that you might have two individuals, but one individual's behavior is showing that it's trajectorying in a more increasing risk, whereas the other person, actually their reliance on acute care is decreasing over time. And then we incorporated area level ESTO, some examples: local healthcare resources, poverty level, air pollution, and then individual level ESTO. This is incorporated in the TMSIS data. For each person, they provide metrics on number of individuals in their house, their income level, their citizen status, what their first language is, and so forth. And then for our model comparison, we did a two-stage analysis. In stage one, we modeled each patient's probability of disenrollment. And this is a really interesting thing about Medicaid. Roughly 25% of Medicaid patients churn in and out of Medicaid. And so they might have it for 3 months, then they lose it. They might have it for another 2 months, and they lose it. And you find that that's really common. Whereas with Medicare, once you get Medicare coverage, you typically have it until you pass away. And so by only keeping those patients that always have Medicaid, you basically cut out 25% of the Medicaid population, which is roughly 25 million Americans. And so what we said is, let's create a two-stage model. In the first stage, let's predict an individual's likelihood of remaining in Medicaid for an entire year. And then in the second stage, then we can predict the probability of then we can predict the probability of an acute care visit for non-emergent conditions, but we'll include the probability of disenrollment as one of the predictors, in addition to area level ESTO, individual level ESTO, clinical features, and patient demographics. That way, we'll understand, do patients that churn out of Medicaid or have Medicaid for a few months, does that increase or decrease their likelihood of an acute care visit? For some, it might decrease their risk because they're in Medicaid for a shorter period of time. And that might inform how a community health program prioritizes patients. For others, it might increase their risk, right? We might hypothesize that, hey, these are folks that don't have Medicaid, therefore they don't have time to establish a relationship with a primary care physician. And therefore, if they get sick, they're more likely to just go to the ED or hospital in order to receive care. And so understanding whether this person is going to remain enrolled in Medicaid for a longer period of time might be helpful in the prediction of whether or not they rely on acute care services for non-emergent conditions. And then what we did is we tested multiple algorithms. We looked at logistic regression because our outcome is binary. We did a regularized regression with ElasticNet, which is a machine learning hyperparameter. We used random forest and then XGBoost. Random forest is a bagging algorithm. XGBoost is a boosting algorithm. And XGBoost in particular is really good both in prediction and optimization, but it's really good when you have a rare label, meaning there's class imbalance in your label. So one thing about acute care, it's really costly, but only about 10% of Medicaid patients use the ED or hospital in a given year. And among that, roughly 50% of those visits are for non-emergent conditions. So only 5% of total Medicaid patients use ED and hospital visits for non-emergent care. And so that's where XGBoost becomes incredibly powerful because it's really good at prediction for an imbalanced label, 5–10% prevalence. And then our performance metrics, we use the Matthew correlation coefficient. This is a really nice metric that balances sensitivity and specificity. I find that it works more effective than F1, but we included F1 in our paper. CSTAT, or the AUC, is another metric we used, and then sensitivity and specificity. So sensitivity is really important because we want a model that's really sensitive, meaning that it's predicting the people that are going to use acute care for non-emergent conditions correctly, because we want to send our care workers to them. Specificity is just as important for us, but for a slightly different reason. In our model, we have a fixed number of people working at Waymark. We have a fixed number of community health workers. And so when our model specificity is low, that's basically saying that the model predicted that that person would have an acute care event, but in reality, they didn't have one. So if we send our resources to folks that the model says will have an acute care event, but they don't have one, that basically limits our ability to target those individuals that will truly have an acute care event. And so that's why specificity is really important. We don't want to unnecessarily use our community health workers and direct them to patients who aren't going to benefit from their services. Whereas sensitivity, we want that to be high because that's the model said that that person would have an acute care event, and they did, right? And so we want that specificity, sensitivity as high as possible, because that enables our ability to say that our model accurately predicts people who truly will have an acute care event in the future. And so the results. So this is just a little bit of this is just kind of a, how do I say, a prelude. The results are much more robust in the paper, but I want to highlight a few things. So one thing is our model basically said it was our best model. Our best model was the one that incorporated all the features, including area and individual level ESTO, and it used XGBoost. And that model had 3x higher probability of predicting non-emergent visits ahead of time compared to the conventional model that used logistic regression and your basic features, baseline features. When it came to prediction of cost, we found that our model, compared to the CDPS algorithm, 10x better prediction of cost, meaning R squared was roughly between 0.25 and 0.4. CDPS historically has been somewhere between 0.02 and 0.01, 0.09. And so anywhere up to 10x better prediction of cost. Our accuracy of our best model was 90.2%. We were able to validate it across 30.6 million Medicaid patients compared to the previous model of roughly about 3 million. And our model actually neutralized the black-white prediction bias. And what do I mean by that was when we look at our sensitivity and specificity by white versus Black patients, we actually found that our sensitivity and specificity was high for African-American patients. What does that mean? That despite some of the challenges in claims data, as I mentioned earlier, by incorporating ESTO, by incorporating some new machine learners, by incorporating some new features of risk trajectories and cumulative risk, and by using an outcome predicting non-emergent acute care versus cost, we were actually able to increase sensitivity and specificity, meaning that our care model would direct more community health workers to African-American patients, and in many ways because they had higher health needs. And here's some of the metrics right here that kind of show those. And so I'll talk about the limitations and some of the discussion, and then I'd love to kind of open it up to questions and both about the study itself, but sort of the broader application within the Waymark ecosystem. So first, our analysis excluded 23 states. As I mentioned earlier, we did a quality check, and we were only able to incorporate 25 states in Washington, D.C., or 26 states in Washington, D.C. So it wasn't a national analysis, but it did include roughly 1/3 of all Medicaid patients in the United States as of 2019. We used the claims-based algorithm to categorize, ED visits and hospitalizations as non-emergent, and oftentimes, there's a broad literature on the NYU algorithm and some of its limitations and how it might overlook some contextual factors that influence some of that utilization. We omitted 2020 due to COVID, but we think that once newer data is available from TMSIS 2021 and onward, we may want to recalibrate our algorithm to reflect more recent utilization patterns among Medicaid patients. And our model excluded dually eligible Medicare and Medicaid patients. And I think this is a big part of that is because Medicare patients have their own outreach programs. However, we also recognize that 10% of Medicare patients are dual eligible. and a Medicaid patient is dual eligible, and these are the high cost or high spenders. It's the individuals that are older, disabled, but also come from low income backgrounds. And so they have especially acute healthcare needs. And so, some of the discussion, it achieved the largest and maybe most generalizable risk model comparison to date. I think the previous largest analysis had about 4 million individuals. There was no counting of race ethnicity. It was across 7 states. And so there was some limitations on generalizability. We achieved higher performance than any other Medicaid risk model in the field. I think a lot of this was just the inclusion of ESTO in conjunction with using some machine learning models. And so in many ways, it was just kind of an update using the more recent innovations in prediction. And so for predicting non-emergent acute care visits, the best performing model tripled the probability of prospectively identifying at-risk patients versus a standard model without increasing false positives that could reduce the efficiency of Medicaid outreach programs. And when predicting costs, our best performing model outperformed the most common model used by Medicaid to date, CDPF, by about tenfold in terms of the coefficient of determination, or the R-squared. One thing that we found was incorporating cumulative risk and risk trajectories substantially improved model performance, as did incorporation of ESTO metrics. And importantly, our XGBoost machine learning model also was able to capture complex interactions of behavioral health and somatic health conditions, which are known in the literature to increase non-emergent acute care, but are not currently included in Medicaid risk prediction models. And I think the final and probably the most important from my perspective is, we found that our modeling approach reversed the lower sensitivity of risk prediction for Black versus white patients, a bias present in standard cost-based models. And I think this, we ran a lot of sensitivity analyses where we included race, excluded race, and performed some other analyses as well to see if that, our ability to, predict risk for African-American patients persisted. And so we found that even after those sensitivity analyses, that result persisted. And I think one persistent challenging in developing risk models is that claims data typically reflect higher healthcare access among white patients. I think our modeling approach showed one strategy to mitigate this challenge, offering a possible approach to more equitable application of machine learning to Medicaid risk model. So I'm going to stop there and say thank you. But what I was hoping to do is maybe offer some more time to have conversations, whether it's about this piece in particular and some of our results, or the broader application of this work in Waymark's care delivery model, or if you just want to learn about, like, what is Waymark? How do you guys earn money? Who are your customers? How does this fit into that? It's a really fascinating world with how Waymark partners with the MCOs, the UHCs, the CVS Health, how we're considered a wraparound program, how our contracts are structured, how HEDIS metrics and quality measures are then included, how we have to report back to the states and the MCOs. So I'm happy to answer questions from an analytic perspective, but also a policy or more of a business operations perspective.
Tara, looks like you have a question. Go ahead.
Hi, thanks so much for the talk.
Yeah.
I'm really curious about the kind of the way that this model is implemented and the work that is done broadly. I'm wondering if you can speak a little bit to how the interactions between the community healthcare workers and the outreach program that's done, how that happens and how it's received by the communities that you're working with. I'm also curious if these models are informing the way that people are reached out to, that only certain people, or greater effort is made with certain populations. Is that communicated to them? Are they kind of aware of this more persistent thing? How is that perceived, or is that completely hidden? All of that. Thank you.
That's a great question. So I'd say like threefold. So I'll kind of tell you the sequence of events that have to happen, and then how this risk model is built into our, we have an app that all of our care workers have access to. And so and how the sequence of patients are ordered based on sort of these data science insights, and how it all flows through our care delivery and operations teams. So I would say three things. Like collaboration, cross-functional integration. That's such an important topic. I think making the transition from academia into industry, coming from industry, initially academia for a number of years and then back into industry, you forgot about how important it is to not only be very careful in terms of apply a very rigorous level for building these data science tools, but also that communication in terms of how you make that understandable to folks on the care operations side, and then how that's then made understandable to the actual care delivery team itself. And there's sort of a layer between us and the care workers, and that's the care ops team, and they sort of turn into that translation. And so stakeholder engagement, incorporating them early, getting their thoughts, making sure that this actually is a problem that's worth solving, understanding what success looks like from an ROI, from both in terms of health outcomes, care delivery, et cetera. They have all these metrics, and how does that feed into that? And so aligning on that early on. And so that's one component. So our contracts are with the MCO. And so we have to sign a contract with ABH, CVS Better Health, and that's been publicized in the United Health Washington. And so that's our customer. But in order to deliver care to Medicaid patients, the state mandates us to also have partnerships with their primary care providers. Because remember, the state controls the Medicaid patient. They moved from a fee-for-service to a managed care. And so they hire commercial entities who created a Medicaid arm like CVS Health, like UHC. And effectively, they have to then contract with their state. And so one of the mandates is every Medicaid patient is assigned to a primary care physician. And in order to deliver care to that person, you have to have an agreement with both the MCO, that's our customer, but also the provider, because they have to give us authority to deliver care and be a wraparound service for the patient the state has assigned to them. And so, those are two people we have to get written verbal agreements on before we can even consider a patient as one of our patients. And then finally, we have to get the patient to consent, and we have to do outreach and we have to find them. But before we do that, we have to figure out which patients do we want to exert effort to search for in the community. And that's where this risk model comes into play. Basically, right now we have roughly 60,000 Medicaid patients. I think we'll double this year. We don't have enough support to deliver care to all 60,000. And so this risk model basically cuts that 60,000 to about the top 20%. And that's sort of that list. And then we build this risk model. We provide insights as to why that person is rising risk. And then that gets filtered through the care delivery team, in terms of this is what we need to see, this is the score we need to have, and then they filter it to their actual care delivery, and they day over day or week over week say, these are the patients we need to target this week. These are the reasons why. And so when you call them, and they have a whole operations about how to do outreach, how to develop rapport, how they're informing those patients of why they want to help them, what they can be helpful with, and so forth.
That's really helpful. Thank you so much. And super cool work. I think it's really important.
Oh, thank you.
Yuta, you can go ahead.
All right, yeah, thank you so much for the talk. This was very interesting. So I had like a few questions about kind of the modeling and prediction tasks. So I was wondering if there's or you saw any differences in model performance, like sensitivity and specificity, like across different regions, because there may be different subpopulations of Medicare patients that maybe need to be modeled separately if their kind of relationship between the patient characteristics is different. And I was also wondering if another question is whether a censoring bias could be introduced for predicting acute care utilization, because in your original data set, you might not observe like the outcomes, specific for patients who are disenrolled from Medicaid.
Yeah.
So yeah.
Yeah, that's a great question. So for your first one, that's something that we're looking at, like whether, so from a business perspective, because Medicaid it functions at the state level, we could potentially norm state-specific models and then roll those out to states in some ways as sort of an updated Medicaid risk model, right? And so I think that's a phase 2 of our program, understanding the variations across states and creating state-specific models. Because if this was, Illinois, and I have the full data set for Illinois patients through 2022, I would rather just norm a model specific to Illinois residents versus the national data set. I think for our analysis, so we created county and state level fixed effects to account for the between state variation, but also the within state between county variation that we find in acute care utilization. But to answer your question, though, no, we didn't do that. But I think that's sort of the next step, especially as we think about creating state-specific models for those states that are interested in sort of adapting or creating a new generation of risk models that phasing out of the older risk models that they rely on currently. The second question, yeah, it's actually a really interesting one. So you said censoring bias, right? So my understanding of your question was, you have folks and they're enrolled, but they churn after 3 months, right? And so you're not going to have 6 months or 0 months of, you have 0 months of that 6-month window that we're measuring the outcome in, right? I think that's a great question. I think that's something that we likely want to think about in terms of like a survival analysis framework. I think there's a new updated machine learning models looking at survival analysis. I think there was a paper in JAMA that did something similar where they were actually looking at risk to death and for a particular type of life-threatening illness. And I think we cited that in our paper. But no, we didn't. And I think that's a really valid point. I think one of the ways that we tried to overcome this issue that people, about 25% of the Medicaid patients annually churn out or have less than a year of continuous enrollment, was by running a 2-stage model. But I think your point's well taken that you're going to have a lot of folks among that 25% that's just going to have a 0, where the counterfactual is they may actually have an acute care visit had they been continuously enrolled, and we're missing that.
Very great, Kay.
Hi, thanks for your talk. It was super interesting.
Absolutely.
I was wondering, so you talked a lot about how you felt that the inclusion of the social determinants of health was something that really improved the predictive of your model. So I was specifically wondering if there were any specific predictors of the social determinants of health that were helping to improve the prediction bias seen in Black patients.
Yeah, that's a great question. And I'll point to the paper. I think in the appendix, I forget where, but we incorporated the feature importance. And I think that might be of interest, Kai, to visually see. I think yes. So I think some of the, and we look at the interactions too. And so we look at the interactions between ESTO and some of the clinical features that we found that were highly correlated and we found repeated in some of our trees within XGBoost as well. I think some of them were air pollution was one. That was a community factor, and we found that often interacted with folks with asthma. I think another one was individual level income, and so TMSIS provides for each patient their where they fall in the federal poverty line, so under, at, 1.5 times above the federal poverty line. So it gives an indication of their household income. And we also found, interestingly enough, individuals who their first language wasn't English was predictive. And so non-native English speakers. And I think that speaks to just the difficulty for native speakers to traverse the healthcare system, especially if you have Medicaid. I imagine the complexity that's involved if you're a non-native English speaker trying to traverse the Medicaid healthcare delivery space and trying to book an appointment with a primary care physician, trying to figure out the prior auths involved. It's a very complicated system and frustrating system to navigate. And so I think, U.S. citizenship was another one. If you weren't a U.S. citizen, that was also predictive. I think that just speaks to just the general challenges for anyone to traverse Medicaid or healthcare in general and trying to get access, let alone individuals who weren't raised in the US or are non-native English speakers.
Great,
Hi,
thanks.
yeah, absolutely.
Young, you can go.
Hi, thank you for the great talk. This is sort of a more like meta question, but I thought sort of we have students that are mostly again in academic research.
Yeah.
Most of our background is in working within a hospital setting, right?
Yeah.
I was sort of interested in like we all have parallel goals, right? Working in a startup, large big tech company, in a hospital, we all want to improve human health outcomes. A lot of times we use the same tools, but I was wondering both on sort of like organizational level and on an individual level, how these different sort of environments affect the way you think. Oh, sorry, Karthik, what? Oh, sorry, like sort of the way, how does that change the way we as individual like employees work and also sort of how the organization moves?
Interesting. May I ask just a quick follow-up question?
Sure thing.
Yeah, I just want to make sure I'm understanding. So are you interested in understanding how these different systems work together or can work together or work in parallel to address the problem?
I guess it's more of a question of one, like if you're in a startup, right, you have a certain amount of, like a finite amount of runway, right? You have to focus on burn rate, you have to focus on, you're constantly focused on, like when do we IPO, et cetera, et cetera. Whereas in academia, you might be working on more like 5-year cycles, right? Like an R1 grant, et cetera. Whereas in a big tech company, you might be more focused on whatever, like inflation. Yeah.
I'm with you now. Yeah, 100%. So, I'll speak in general terms, but I have peers in academia trying to do the same thing. I think one of the challenges that they run into, let me backtrack. Waymark's in a really unique position. I think, with their funding, our heads, I say we, but our leadership, secured, I think 90 million for Series A, which gives them a lot of runway. And they were able to also get CVS Ventures on board as one of their partners. And we also deliver care to CVS Health Medicaid patients. And so they're in a unique position where there is resources to expend. The burn rate is low, but also there's a lot of runway with a Series A of like 85, 90 million. And I think what that allows us to do is it gives us the ability to experiment in ways where other health tech companies may not have that luxury. I think a second component goes to our leadership. I mean, look at Sanjay Basu on Google Scholar, machine learner, both for causal inference prediction, did a lot of evaluations of community-based models, spent 7 years at Stanford. And I think what I'm trying to say there, it speaks to the value of what what leadership values. And I think in terms of rigorous research, data science, a lot of the decisions we make have to be data driven. A lot of the tools that we build go through a really rigorous process. And I think it was just the kind of the perfect marriage of those different components. And I think what your leadership values is going to trickle down to the type of work you do. And so if you value like rigorous research and using updated models and moving swiftly, but maybe that doesn't align with what your leadership also values, you may find moments of frustration, given that your skill set isn't valued in a way that maybe your chair of your dissertation valued it. And I think that's a synergy you want to look out for. And I think having a co-founder who really believes that data science is the future for healthcare and healthcare delivery, and that's what's going to differentiate Waymark from any other care delivery program, but also just healthcare companies in general. And I think everyone believes that now. Everyone thinks AI and LLM, but the question becomes, how do you use it? And what problems are you solving with an LLM? And how is your application of the LLM unique and different and addresses the problem in a way that actually gets at the heart of the challenge? And what is the level of robustness? What a level of ad hoc sensitivity? What are the evaluations you're doing after the fact for A/B testing? Maybe rolling out one model to one market and not to the other, and seeing how they, and how do you evaluate that? And I think that's a big part of the work we do. Like I think we publish anywhere from 3 to 5 papers a year, both on the tools we build, but also more broadly, like the evaluations. And we publish null results too. So I think that's one thing. I think the second tension that you talked about was sort of the runway. Our runway is a year. Our runway is like 2 or 3 years, but we're really working by the end of 2025. 2024, we want to be in a place where everything is in production, and now we're evaluating and making quick decisions. In academia, in like an analogous role that I may have considered in a previous life, that runway is 3 to 5 years. And so it really depends on what your sense of urgency is. And, if there's excitement in doing things quickly and pivoting, or if there's excitement in doing things slowly and really understanding at a granular level every step of the process, versus riffing quickly and pivoting quickly, and sometimes feeling like you are incompletely exploring things before you change path altogether because of the shifting business needs. I think that's always a tension. Whereas in academia, you have the ability to really sit and think and allow your thought process to lead your path forward versus like business needs and urgency.
Thank you very much.
Yeah.
Aziz.
Hi, so my question is about, you said that there were some unique feature combinations or certain things you extracted from the model. I wanted to ask how you see these kind of models being used in healthcare settings, or by, let's say, private companies or startups to intervene on certain things and prevent, rather than just be used as risk models.
Yeah, that's a good question. So I think you're kind of touching on some of the work we're working on now. So I'll be really clear, like this is, ML for prediction, right? So we're just predicting a classification question, but we'll call this sort of next gen, we're working on ML for causal inference. So like heterogeneous treatment effects, right? And so the problem that we have now is we've identified our rising risk patients and we're calling them. But not all patients are equally deserving of healthcare and great healthcare access, especially Medicaid patients. But the question is, not all patients are going to equally benefit from our intervention. Some patients are going to have healthcare needs that are flagged as rising risk that Waymark just isn't equipped to deliver that care for, right? For example, we have a whole behavioral health arm filled with licensed social workers. So Medicaid patients with mental health care condition, we're probably very well equipped to deal with that. Substance use, equipped to do that. Patients with really chronic healthcare needs, maybe we're not, because we don't have physicians on staff. We have a nurse practitioner, but their role isn't really to deliver clinical care. And so what heterogeneous treatment effects allows us to do, and there's a whole literature on it, is it's ML for causal inference. So it allows us to look at the impact of receiving our intervention, right? And what it does is it gives sort of an ITE, individual treatment effect for each patient. And it predicts, based on the features in the model, will we see a reduction in future acute care visits or an increase, right? And what you find is that distribution is like this. You have it from negative, kind of normally distributed, all the way to positive. And when you look at the negative folks, you see that they cluster with certain characteristics. And you look at the folks that are actually increasing, they have healthcare needs that, like, they need something more, a more intensive treatment that we just can't provide. Something that requires a hospital setting or a doctor's office, not a community health program. And what that allows us to do is it allows us to not only find those rising risk patients, but sort of do a second level of filtering, where we reprioritize patients that will benefit most from our intervention through this heterogeneous treatment effect analysis. And then what we can do for those patients that are rising risk that won't benefit, how do we find alternative mechanisms? And we have partnerships with their primary care, we have partnerships with the MCO, and so we can work with them to understand, like, well, you have these patients, they're high risk or rising risk, but we just don't, their needs are not going to be adequately addressed by a CHW program. How do you want to address those needs in an alternative mechanism? Does that help answer your question?
Yeah, absolutely. Thanks.